that Michelle was able to join this morning, so I'll ask her if she wants to say a few words as well. I wanted to just provide a little context for the draft report in case you were not on the last meeting. I mentioned at that time that even though this group was not legislatively mandated and we don't have a report mandate, that I wanted to be able to share our work with others, specifically the legislature, in the upcoming session. And so we put an interim draft report together, and today want to get your feedback on that, because our intention would be to finalize it and have it available. We know that there will be legislative debate around nursing homes this session, because we're preparing we're preparing a rate reform proposal that will be discussed and to some measure debated during the legislative session. That rate reform proposal has, what I like to think of as a down payment on quality, in as much as it has a heavy emphasis on direct care staff and ensuring that that's adequate, because we know how important constancy and adequacy of direct care staff is to quality. And then we are also proposing a value-based payment for the first time in nursing homes. And so I think those things are necessary. They're not sufficient, and there's so much more work that this group can help us with in the future if you're all willing. So, but I wanted to just let you know why I think it's important that we lift up the work of this group, so that the quality piece is not forgotten in the legislative debate, which will largely be about money, because that's what the debate generally is in the legislature. So with that, Michelle.
Good morning. Thanks everybody for being here on this crazy week. I'll just echo Paul's comments and say that it's nice for me to have been able to participate in this group, although I haven't always been able to be at every meeting, but the discussion has absolutely informed our broader conversation about payment reform and thoughts for the future as well, and echo also Paul's thoughts and wish that I would love to hear quality be elevated in the conversations this coming session as well. So thank you.
And so with that, I'm going to turn it to Lauren, who gets the lion's share of the credit for putting the draft together, and who will walk us through the draft and help structure our conversation. That said, we're open to any kind of feedback in any way, and we're also going to give some time for written comments for the next couple of weeks, but we are interested in getting your whatever you're willing to share verbally today. So Lauren.
Sure. How about some slides, Sarah? Great. Next. Okay, so what we did is we again tried to capture everything that we have learned from reading what's going on nationally, what we've heard within this group, and tried to sort of capture what the main themes were for us to sort of make sure that we heard you appropriately, and also for anyone else who may be interested in what we're doing. So what I've done here is take the 4 major themes, as well as the 5th theme, which is more observational, and taken the little narrative from the executive summary, just so that it would be available for discussion here. Again, the document's pretty long and wordy, but I think the summaries are enough information to capture what these were. And the first theme was a stable, well-trained, well-supported workforce. I'm just going to read this. Again, it's based on the more detailed information in the report. A stable, well-trained workforce is the foundation of a facility's ability to deliver high-quality care. Many facilities struggle with recruiting and retaining direct care staff and support staff. And then we talked about some of the barriers, which include pay, high patient loads, the hard emotional and physical work. I think we heard that so clearly from our panelists last month. Stressed colleagues, perceived lack of respect, constant threats of burnout, and solutions will be complex and multimodality. Okay, next. Next slide, Sarah. Okay, we heard frequently about the need for autonomy among our residents, and the implementation of true person-centered care requires the completion of care plans that puts the resident first. Care plan must contain all the elements that a resident uses to define their personal quality of life. The foundation of person-centered plan of care is the sum of relationships between a resident and their care staff. So I think we heard that clearly again several of our sessions, that it's really not about the care plan, it's about the relationships that sort of get embedded within the care plan. And once we deliver person-centered care, it's rewarding for staff. People feel better about the work they're doing, conveys value and personhood to the residents. Next slide. Excellence in clinical care. Maine's facilities, and this comes from the information that we learned from Care Compare, right, from the 5-star ratings system that CMS implemented years ago. And what we found is that Maine's facilities demonstrate opportunities for improvement in rates of falls, rates of urinary tract infections, antipsychotic prescribing, and emergency room utilization. We also found that there is no person-reported outcome that's included in any publicly reported outcomes. So we think that that's necessary to implement moving forward. Next. Safe, comfortable living spaces. Yeah, we learned a lot about small house models and the impact that can have on both employee satisfaction as well as improved outcomes for residents. So when facility environments transition from an institutional model to one that more closely aligns with what feels like home, residents and staff find opportunities to develop meaningful relationships that support better clinical outcomes for residents and greater staff satisfaction. Next. So this wasn't necessarily a theme as discussed here, but when we looked closely at our data, specifically our STAR data, and tried to look at the differences between urban and rural and more super rural areas, it sort of seems to be starting to tell a story that there might be a disparity in healthcare access when comparing urban to more rural areas. In particular, it looked like emergency room utilization was higher in our super rural compared to our urban, and this could lead to unnecessary untreated medical conditions, unnecessary emergency room visits, greater inconvenience for the residents in more rural facilities. It may also be leading to extra costs. Super rural. There's a question in the chat from Maureen. Sure. So there's urban, that definition of urban, and then there's the definition of rural, which is everything else. So, and then you take the rural areas and sort of from the top down, it's the lowest quartile. The lowest quartile of rural is your super rural, and they're predominantly in our down east and northern counties. Okay, next. So, as Paul mentioned in opening, what we're hoping to get is some input from you all that helps us make sure that this report includes all the necessary components. So, we'd like to just start by getting some feedback from you. The first point here, the first question: do the themes capture the most important ideas discussed? Is there anything that you would add or remove from these themes? Anyone want to start us off here today?
I will go ahead. I think the themes are great. It's a terrific report. I think the one that relates to person-centered care, autonomy and person-centered care, is the toughest for people to get their head around, because it can mean nothing or it can mean something really important. And I just wonder if even in the themes, if it wouldn't be important to add something about meaningful life, relationship, because autonomy is actually, from people I've talked to, a little bit less important than having something meaningful and feeling connected, often to family or community or even to other residents. So I know there's some mention of that later. I just think it's so important.
Yep.
Thank you, Barbara.
I'll put my hand up.
Hi, Ruta, go ahead.
Hi, these are kind of half-baked thoughts. I was trying to figure out how to formulate it after reading the report, and I'm still not sure. But there are two of them. One is kind of the integration across the themes, like they're highly interrelated, you know. So the person-centered care is impossible without the adequate and well-trained and well-supported staff. And clinical care is kind of necessary, but not the excellence in clinical care is necessary, but not sufficient to all the right to, you know, quality of life, right? And so it's that intersection across them that I think merits maybe a little bit more attention. And the other is, it struck me in the piece about healthcare access in rural and super rural places. Like there's the piece about access to medical care beyond the nursing home. And I know there's another group looking at needs assessment across the state, I believe, but I wondered about the piece of, you know, shrinking access to nursing care in rural and super rural places as facilities, you know, close. So there's that.
Heidi.
Thanks, Ruta. It's particularly on the cross-cutting. Our own critique is that it needs more discussion. And so I think we can introduce the themes a little more with the cross-cutting, but then we can also do a little discussion after we present the themes to talk about how they're really interrelated.
Oh, and that was so clear trying to piece it all together. You know, I'd be writing a little bit about, you know, small house models, and then I go back to person-centered, and then I go back to staffing, and I was my head was spinning, you know. Yeah. I'm sorry, go ahead, Heidi. I think you had your hand up first.
Oh, I love the greenhouse model and appreciate the presentation, but I also think part of its success is the high staffing ratios. And when you go to CMS Compare right now, Maine Veterans Home Augusta has 6 hours and 53 minutes of nurse staff hours per resident per day versus most others having maybe 4. The Maine average is 4 hours and 30 minutes. And so as much as the model is amazing, I also think we can't discount the staffing level. And I think they were also very clear that the staffing came because they got extra funds from other sources than where a lot of other homes get funding, like from the state or maybe a little bit of private pay. And so I just feel like we have to really call that out. The staffing ratios just are not adequate to provide the quality of care that we want to have for our residents.
Thank you. I think Barbara, you had your hand up next.
I was going to say, considering that the legislature is part of the audience that you're looking at, I think, would you want to include a theme that relates more to cost? And I know we've had lots of discussions about, and it's sort of sprinkled through the report about things that add to the cost: hospitalizations, staff turnover, falls, so improving mobility. I mean, so there's a lot of things that are related. Maybe this is another one of those cross-cutting things, but I think a lot of the things in here add up to additional cost. And if the legislature is going to be looking at this and cares largely about that, it would be important to directly tie these issues to cost, I think.
Do you have any comments about that, either Paul or Michelle at all?
Yeah, I think it's an interesting comment. And we did do some analysis looking at whether we found a relationship between cost and quality. And And it might be worth calling that analysis out, because it was kind of it wasn't super straightforward. On one hand, there clearly seemed to be a correlation to some extent between higher cost facilities and the CMS stars. But on the other hand, there was quite a bit of variation, and we had some very low cost facilities that were very high quality. So it wasn't super predictive, but I do think that it is worth noting.
There certainly is literature research that looks at the increase in hospitalizations and the cost of staff turnover.
So also talking about the subsequent costs of lower quality care.
Right.
Yeah.
Judy.
Wonderful job on the report. I'm wondering if it's worth talking about going a little further, even if it's in the appendix, to offer some call to action. It seems like it would be a missed opportunity to not crosswalk the National Academy report recommendations for state agencies and tie them to the themes. It would help policymakers see where the path is. I mean, yes, it's money, but what are you going to spend your money on? And for example, I was thinking about there's a part in the National Academy report about the space. And one of the recommendations to the states is to only use, to change new funding. And when facilities are approved, this is what they should have, or facilities are renovated, this is what they should have. Another one, for example, was talking about student loan forgiveness for staff who work in nursing facilities. So those kind of things, I just throwing that out there.
Thank you.
Yeah, I like that idea a lot. And if you're willing to follow up with some of these specific things you're calling out from the Academy report, that would be really helpful.
Rich, I think you're next.
Thank you. I think this is a great a great job. One thing that I don't recall us discussing, and it's possible it could have been discussed at the meeting that I was not able to attend, but even within a facility, there seems to be a huge discrepancy of quality of life with depending on payer source, whether they're private pay or main care. And one thing I've asked a lot of my residents, like what some of these things are, is because the allowance for them to keep only $40 a month for their own spending is a significant problem. In my understanding, it's been that way for a long time. Some people have told me it's been decades. It's been $40. I know that Massachusetts is at least 80, but I think with the inflation and the cost of living increases, these residents, after a haircut, they can't really do anything. They see other residents getting DoorDash or ordering things online, and it's hard for some of these main care residents to not have any funds to be able to do anything discretionary on their own. So I think we have a position to possibly make a recommendation to increase that allowance that I think would improve the quality of life of probably the lower tier socioeconomic residents that live in our facilities.
I think that's great. I think that's a great suggestion. I mean, I think it goes to the point also that we don't have a good way to measure quality of life, and we certainly don't ask the residents at this point, right? We don't,
there's a huge, I'm at St. Joseph's in Portland, and there's a dollar store down the street, and they take their scooters and their wheelchairs down there, and they love going to the dollar store, and they come back and show me everything they bought. And, just buying little presents for each other or their families, or getting takeout food every now and then, those are the little things that we take for granted that these residents really light up. And it's a funny story too. When they play bingo, they play for money and they win like $1 or $2. There was someone who donated $50 to the bingo, and it was almost a fist fight, because thinking about doubling your monthly income by playing bingo at the nursing home. And so it was very competitive, and it was a little sad to see how a few extra dollars makes a huge difference to these people.
Thank you.
We'll look into that, Rich. It is, I believe that there is state discretion in the needs allowance that remains after the state calculates cost of care for main care residents. It's what they're left with. And so I think we understand the issue and we'll definitely look into that.
Ruta, I think you're next.
Thanks. I would say, yeah, here to that point on the residents needs allowance. I mean, I think that calls a bigger question that is probably beyond the scope of this group, but it also struck me in reading this report. I feel like, there's tinkering around the edges to try to improve the current system. And then there's really thinking about, what would a system that we would all really feel good about look like, and one piece of that would be, not forcing people to impoverish themselves in order to get care. But that's an editorial comment, I guess, because it probably is beyond the scope of this committee. But I would love it if the report did call out the need for kind of more transformational reform of the system, even while acknowledging that that's, this is incremental. I think that would be a huge step. The other thing I just wanted to go back to on the piece about cost, I agree about trying to capture something about that, Barbara. I thought that was a good recommendation. Again, sort of beyond the scope of doing it in this report, but maybe say looking forward, that it would be important to really look at all the elements of cost in facilities operating on different models. So I hear you on the staffing ratio piece, Heidi, that you talked about. And there's also sort of bigger shifts in where the money goes to staffing in the greenhouse model. So it's about thinking about putting dollars and cents as close to the resident as possible. So yes, it is increasing the cost of those direct care staff by having more of them, but that money also, some of it at least, comes from other elements of facility operations that are really fundamentally shifted in that model. So it's not just a net increase. So I think it's important to look at that bigger piece, and also thinking about offsetting savings. There is real money in turnover, in reducing turnover, even within a facility. And then there's the offsetting savings of quality care and avoided negative outcomes that have costs. So, yeah.
I think we'll go to Mary Lou next. And then, I don't know, Paul, should we move to another question after that, or how do you?
I don't know. I think we're going strong here. We ought to keep this going. That's good.
Great. Mary Lou, go ahead.
So thank you, Lauren, and others who worked on the report. I agree. It's just nicely done. Thank you. When I read it, what jumped out at me, of course, was not a gap in the report, but a gap in our conversation this year that maybe we can add to if there is a looking forward part of the report, or just in your internal conversations, maybe you could put this on it. So what jumped out at me was, clearly the root cause of so many of the quality issues in long-term care everywhere is, the elephant in the room, which is our ageist culture. And I know those of you who know me well are going to say I'm a one-trick pony, but it's real. Like, we know this is real. So maybe next year we could have some conversations around, what's the low-hanging fruit to addressing ageism, which is the long game, right? But there is some low-hanging fruit. For instance, changing curricula for direct care workers, CNAs, CRMAs, PSSs, to include a module on ageism. We can create some best practice tips for long-term care leaders, around language and, everything that's at the root of much of what all of you have said, like relationships and retention of staff, is around, the equity between the staff and the resident, and how do we create meaningful relationships when there's this enormous thing hanging over it, which is historic marginalization of older people and dismissiveness. So I would love to see that on the agenda for next year, and maybe noted in this report as something that we'll take up.
Yep, thank you. Brenda, I see you've had your hand up and down. I want to give you a chance.
She's been clapping.
I'm so I keep thinking, what am I doing wrong here? But anyway, so first I want to say I love the report. And I just really appreciate all the comments, and I agree with everything everybody said. I was really pleased to see workforce first on the list. And I'm really so pleased that people are thinking about staffing ratios. That's something I've been interested in since 1999. So, and I think Maine took some initial steps. For a while, we were first in the country. Now we're kind of in the middle of the pack. We have our resident population are among the highest in terms of acuity in the country. There's only a couple of other states that are around the same needs of the residents that we serve. I think we really need to think about what we can do to improve staffing ratios. That will have a lot to do with retention. So I'm really pleased that people are talking about this. I'd love to see projects around facilities that are doing a good job in terms of retention. We've been going out and talking to direct care workers and hearing from them their concerns. And in the midst of this, we've met with some leaders that are doing a really good job around retention. So I'd love to see whether it's a CMP project to really focus on what are some leaders doing well that aren't using agency staff, that are bringing in new staff. I think we could do some innovative work because that's really important for us to do. Also, with respect to the antipsychotics, Maine was first in the country when the initiative first began in 2012. We were leaders. CMS really looked to us as leaders in the country. We lost ground during the pandemic. I know Maine Healthcare Association is bringing the dementia partnership back together in the months ahead. So I think you'll see some good work from that group. That's really needed. And I'd love to see a quality work group with providers, the QIO licensing, the ombudsman program, to really focus on the quality needs that we have in our facilities and what we can do around education and strategies to improve quality. I'm anxious to see some of this put into action because we are really seeing quality issues across the state, and it's so discouraging. So I love the report. This is a great start, but I'd love to see us take a step further in terms of, can we actually get some work going in some of these areas?
Perfect, perfect. I want to go back to, I see 3 hands up. Judy, is that your hand still up or? Okay, Barbara, I think.
And before you start, Barbara, I just want to thank you, Brenda. And again, also, if you're willing to send us some things in writing where, places where we could move toward recommendations, I guess is what I'm hearing you call for. And some of the stuff you're talking about is very practical. Like, can we do a CMP project? Because that doesn't need new money, right? It just needs CMS approval. So thank you for that. And you also mentioned ombudsman and licensing. We did have a whole meeting on that, and I'm realizing we don't have any mention of it in the report. So if you have ideas of what we would say about that, I think that could be important to add. Thank you.
Okay, and can I just mention one thing? Could you mention the Direct Care and Support Advisory, Professional Advisory Council? Even though we had a couple of members on a panel, it wasn't mentioned. And I think you're going to be seeing more and more from this group in the months ahead. So
thank you.
Thank you.
I think we referenced them. I did not give it the whole name, but I appreciate that. That's right.
And also the personal needs allowance has been in place since 1972 in Maine.
Wow.
So, and every year there's a bill that comes up in the legislature to increase it. So
It's been in place at that same level since 72.
Pretty sure. I can go back, but
Yeah, it would be interesting to show what its purchasing value is now compared to when it was implemented.
Yeah, I can provide a chart of what the other states are doing and what and Maine, so you'll see the difference.
Right. Go ahead, Barbara.
Oh, okay. I'm not sure if I'm veering off the topic or not, but I just wanted to follow up on, I think, what Ruta said about I'm not sure if it was Ruta, but ageism. And that was one of the things that the residents actually talked about was the staff are lovely, but ageist. They don't really understand how to use language and what it feels like to someone, the honey. And and they also recommended that as part of CNA training, they have training in ageism and how to prevent speaking to someone in an ageist way. But to follow up also on the training, I think for most nursing homes, there is very little meaningful continuing education. They keep getting infection control, they keep getting how to use a fire extinguisher and a few other mandated things. But in terms of actually developing knowledge and skills, there's almost nothing. We did a sort of traveling show around Wisconsin several years ago, and we had mostly CNAs who said they'd never actually been to a training program before, and they'd been working 10, 15, some 20 years. So I think there's a real hole there, and a hunger in these folks to continue their understanding, their knowledge about whether it's disease process. So I think that's also something that could be added in there. And my final comment is I'd love to see mobility emphasized in along with falls or ahead of falls, because I think when people see fall prevention, they see don't let people walk or do anything. And if we could somehow shift the understanding so that's maintaining mobilities while still protecting people from falls, I think it would be really helpful. So it's just a language issue.
Great point. I think Jill, you're next.
Thanks. Actually, this is great to follow you because I wanted to comment on the whole ageist, conversation. Thank you, Mary Lou, for bringing that up. I also think along with that, since people living with dementia are such high users of residential facilities, really looking at increasing staff training kind of across the board of dementia related behaviors, and increasing understanding of those behaviors and how to address it, and that speaks to both that speaks to staffing issue as well, and the retention of making sure people are better equipped to deal with those behaviors that can lead to kind of burnout and job frustration. But yeah, I think those are really important conversations to have. And also I wanted to comment on I really agree with making connections between the themes and how they are interrelated, because I do see that with respect to you need Alzheimer's Association really wants to see person-centered care, and but you need the staffing to do that, and a lot of the things in the person-centered planning can impact fall prevention. When you're looking at each resident's kind of needs and behaviors, and making sure that you're working to look at and prevent things before they occur, while again, retaining that mobility and that autonomy, and not making people feel like they can't move around or leave their rooms. So thanks for all the work on this, and again, just really agree on the staffing and the person-centered care as really important pieces of this.
That kind of gets to another question that we have for you. It's that, in the writing, I think we spent most space on staffing, sort of implying that maybe that is the most important theme to take, or is the intersectionality so significant that you have to link them? I mean, is staffing the most important? We also spent a fair amount of time on space. I think, we just love this small house model. So just again, some questions as to, is there such a thing as a most important theme? Gail.
Thanks. I agree. Great report. So in regards to the section of the themes, I think that, our work with the nursing homes has shown us that when people embark on more person-centered household, whatever model, staffing sort of stabilizes quite a bit. So I think there is a connection there. The other thing that I was just going to throw out is, money's always an issue. And something that has struck me since we started doing a lot more work with nursing homes that are sort of quote unquote in trouble, is in looking at Nursing Home Compare what they're spending in fines. You know, we recently started working with a home in Connecticut that I think has put out roughly $250,000 in the last year in CMP fines. And, you know, how can we work with homes to address some of the things that are getting them into those fines so that the money can be related to something useful rather than just going out the door and not benefiting the residents?
Heidi.
Yeah, I mean, I think staffing is really key and central, stable staffing. I think it's really at the center of person-centered care. I also think it's highly influences the provision of the best medical care. As a provider, we rely so much on the nursing staff to help us triage and identify when things are going awry. And without the stable staffing, I think that promotes people going to the ER, hospital, things like that. If it's not identified early enough, you just can't do a good job unless you have stable staffing in the facilities, stable and adequate staffing. It just it's so hard to do anything else. And I think particularly in our rural communities where you often have physicians and providers whose passion is not doing nursing home work. I'm fortunate to work with a group who's really passionate and enjoys this work and does it because they want to. But I don't think that's the case in all our most rural communities where you have providers that are doing it because someone needs to do it. And so it's not their passion. And without the staffing to support them, I think it's a hard job to do and to do well. So that's my probably more than 2 cents, but.
Go ahead, Mary Lou.
So two things that jumped in my mind as I'm listening to all of you. First of all, in terms of priorities, I wonder if maybe just sort of thinking outside the hierarchy box. You know, I'm a fan of quadrants. I appreciate Heidi's comment about centrality of certain issues, you know, root causes. I don't know, I'm just throwing that out there because, you know, maybe some of us can have a brainstorming session about how to map out all of the issues and then focus on, you know, which ones to, you know, where are there interventions that are accessible, concrete, affordable, all of those things. Anyway, that's one thing. The other, and I don't know if this is the right venue for this comment, but again, maybe something to think about for next year. And I don't know if any of you saw the alarming Washington Post story the other day about residents who wander away from Elizabeth, you're nodding. You know, it just is so gripping, the tale. And for those of us who have been providers, we know that it could happen tomorrow, right? I actually commented on that Washington Post story and found myself, without even thinking, typing out, oh my goodness, the design community needs to have some pressure put on it or incentivize different types of safety mechanisms that don't interfere with autonomy. As you said, Barb, you know, we can't put residents in a bubble suit and lock them in their room. So where are the monitors, the tracking devices, all of those things that give providers and families the safety and security they need, but residents some. Anyway, there's lots of design issues, including the small home model. So is there anything that states could do to nudge local designers, but maybe national designers, to provide us with something that we can test, pilot, use a demonstration? Anyway, just putting that out there. Thanks.
Mm-hmm. Yeah. Maureen?
Yeah, I just wanted to, I really do think that right now staffing is our biggest issue. I think that if we had adequate staffing, it would be easier for people to be involved in more education, to be focused in more quality assurance, performance improvement activities. Right now, as you know, the use of agency staff in the state is just horrendous. And the quality of that, I don't think anyone feels is the best. I also think with that, the costs associated with that really then precludes centers and homes from trying new technology or looking at new design or renovation. I think we've got to figure out how to fix the staffing. And I don't negate the importance of potential technology in helping with that fix. I think there is a lot of stuff out there, you know, talking to people across the country who are using some things. And yes, a robot delivering, you know, your coffee may not be the most, what I would prefer to have us, I'd rather have a person doing that. However, if that allows us to have care attendants at the bedside providing direct care, then that might be the trade-off. But I don't think until we get the staffing issue fixed, we're going to solve anything else.
I'm certainly hearing strong agreement with staffing being the lead issue in this report. And how it then enables the other issues to be addressed.
I feel like we need to think about staffing not just as compared to the national average as well, because Maine has sicker people living in nursing homes than every other state. And so comparing to national, I think undervalues the importance of actually having more staff. And so I think, how do we establish what adequate staffing is? And I don't think that should be on a bell curve. You know, there should be a level that's defined that really shows us what gives the best care. I don't know what that number is. I don't pretend to know that, but I think comparing to other people nationally just doesn't seem the right way to do that. It should be more of a threshold sort of thing.
Well, yeah, and why do you want the staffing? I mean, there's you know, you want it so that you can implement that person-centered care, so that you can have quality care. And so looking at those measurements, you know, in addition to, you know, things like staff retention and you know, job satisfaction and things like that. That's all really important to drive that conversation. And I agree, we don't want to, you know, just kind of aim to kind of get at the middle, because I think we're just shortchanging ourselves if we look at it in those terms.
Yeah, I remember going through the list of, it was like 40 recommendations that the residents that I interviewed made, and almost all of them were sort of undergirded by insufficient staffing. Very few that were not directly related.
Maureen, is your hand still up or are you up again?
Yeah, I just wanted to say that one of the things that has really bothered me with the proposed CMS rule of staffing is I think you're missing a lot of people who bring so much to the quality of residents' life. And for example, people who provide activities. There's a whole group of people who don't want to be nursing assistants, or they don't want to provide direct physical care, but they really do want to take a resident for a walk, or they really do want to play a game with a resident, or they really do want to engage with that resident. And I think we need to be careful that we don't lump everybody into having to be in that nursing care. I think there has to be an adequate number of those people, but that we have to balance that, and especially in this the difficult staffing challenges.
Thank you. You know, it's just, I don't know how to ask this question, but if we could make the experience of being a staff person better, what would it be? I mean, is it only pay? What is it? What are the things we can do to make the experience of being a frontline caregiver better today?
It's all about the relationship. That time to get to know your resident and to get to be with them and to hear their stories, and you build that connection, you build that relationship between people. That's what makes people want to do what they do.
Yeah. Barbara.
Yeah, I mean, there's a lot of work that's been done on this, and from what I'm familiar with, I think the big issues are, first of all, insufficient staffing, because staff who really care and can't provide the care that they think the resident needs, they get driven out. So the best people go because they can't provide the care because the staff is so short. I think there are also issues, and this has been shown over and over again, with the quality of the supervising staff, whether it's the nurse or someone else there. If they don't know how to supervise, mentor, coach, and they do things that humiliate, embarrass, or diminish the CNAs, they leave. I mean, these are reasons that are that. And then there's a interesting literature evolving on racism and the sort of racial slurs that our caregivers of color experience, and the inability or the lack of response from the administration. From what I heard, these caregivers said, we know that people, for example, with dementia are going to say things, and that doesn't really offend us. What offends us is that no one says that must have felt really horrible. I'm sorry that happened. There's no recognition of that. And families are not stopped from making racial statements to staff. So those are, I think, three really important things that are not about money.
Ruta?
Ditto everything Barbara just said. And the other thing that I feel like came through really loud and clear in the focus groups that were done a couple of years ago here in Maine was communication, supervisor. So it goes back to that communication vision piece talked about, but I also heard communication. There was like in my job well, and that I count, and you know why I need to be in the loop. You know what I mean? Mm-hmm. So it's a little less tangible maybe, but it's about how people are treated.
Yeah. Joyce, is it Gina?
Gretchen,
I'm sorry. Wasn't counting your name.
I just really want to echo what the last couple of folks have said. We've heard a lot about direct care staff not feeling supported by their leadership. There's a big difference between a DON that'll go out on the floor and assist with the work of a CNA and a DON that's behind a closed door. And we hear a lot about leadership being behind closed doors and being unresponsive. We also hear a lot about, they're caring for these high care needs patients, but they're not being trained on how to care for them. And I think, to somebody, I think it was Barbara, maybe, who said, these are the good people who are being driven out because they're not getting that support. And I think it's just happening more and more frequently. And I also think it's really important that an administrator and a DON have a really tight communication that is funneled down to the staff. And I think staff should be involved in when they do report off. I think there should be some type of communication during reports for direct care staff.
Yeah. Brenda, were you clapping, or was your hand raised again?
This is hilarious. I keep trying to put up my hand. Okay, so I just have to say, retention is possible if you have good management. I went into a facility recently and I left feeling so good, met with all the staff. The administrator came in. He said, I've just been here for a few months. He said, I had to make some changes in leadership. And he said, we don't use agency staff at all. We do extra things for staff, like sometimes we do DoorDash, we do raffles. We acknowledge perfect attendance. We're all cross-trained. He said, last week I was in the kitchen. So I left there and it was such a good atmosphere. And they said, every resident, every staff person knows all the residents, knows their names. It was just such a good atmosphere. And I thought, there are leaders out there like this that understand it's all about management in terms of retention. If you're respectful of your employees, if there's great communication, as Ruta said, and also an acknowledgement that these people, the direct care staff, go into this because they care about people. So if they're in a situation where they're chronically understaffed, where there's not a good communication, they'll leave. So there's some very simple strategies that we can implement and foster across the state to both recruit and retain employees. It's not rocket science. The other thing is also getting nurses, really teaching nurses about pitching in, communicating with the CNAs, because they know the residents and they can see a subtle change in condition that the nurse might not pick up on. So it's about communication, team effort, and we can do this. And again, it goes back to the thought about doing a CMP project around retention. So
Great.
thank you.
Lauren, let's just we got two people with their hands up. Let's do a couple more quick comments, then we need to go to next steps. But
Oh,
this
yeah.
has been an incredibly rich discussion. It's really exciting.
Yeah. Okay, Rich, go for it.
So one observation is that medicine tends to put people in leadership positions because they do a good job clinically, and they're not necessarily trained at how to be a leader. And I see good nurses not do very well at director of nursing or nurse managers. And it's really just because of lack of training. A lot of us who've gone into medicine, steered away from business classes, steered away from all these things because we don't like that world. We like taking care of patients. We don't like thinking about how money sometimes stops us to do some of these things and looking at budgets and stuff like that. But I think that there needs to be an effort to do a better job with training of the leaders of these facilities. And I don't know if that's the responsibility of a state program or holding individual corporations more accountable to it. But I think that without training them as good leaders, it's going to be hard to get them to do the right things to keep their staff and retain staff, and to want people to continue to work for them and inspire their workers.
Right. Reminds me of Marilyn Rance's leadership mentoring program that it's part of her program in Missouri. Okay, Angie, go for it.
Yeah, thanks. I just wanted to say I do, and the many people I talk to, that the relationship with the resident is one of the most important things why they got into this work, and they want to make a difference in somebody's life. But I do think that just the basic fundamental relationship you have with employees, of being respectful of what they say, empowering them to make decisions when they can make those decisions, providing them with some basic training. And also I think the blending of some of the workforce, for example, if you're short staffed on the floor, why can't an OT go in and do some ADLs to help somebody out? Or, we have a social worker that we put as a CNA. So, having some of these blended positions that, can really help them. So they see that you're making those efforts to really, supporting them in their roles in that. But I do think that there should be a basic, fundamental curriculum that's taught or something that really gets to some of these issues, because it's really about respecting people and really telling them when they do a good job and providing that feedback.
Thank you. Okay, Paul.
Great. Sarah, can you just put up our next step slide? And this has been incredibly rich. We are so appreciative. Let's look. So first of all, if you are willing to follow up with written comments, please send them to Lauren by January 5th. At that point, we're going to try to close up this report and get it ready to go. In terms of next steps for the group, because we know at the department that we will be fully engaged with the legislature while they meet, we would propose that we just not have this group meet during the legislative session. It's the short year this year. That would mean legislature is scheduled to adjourn third week in April. We'll see if they make their deadline or not. But we would look to reconvene all of you in May or June and fill you in on the legislative debate and what has occurred. And I know that many of you will be following it, and so on. So we're want to know if that's if that sounds good to you all. And then when we do reconvene, some people have already mentioned topics that we haven't really addressed yet that you would like to. So what are those? And when we reconvene, let me just stop there. I'm throwing too many questions all at once at folks, but you can take this down, Sarah. So first of all, are people willing to continue this after a break for the legislative session? And when we do reconvene, are there other things for the list of topics? We've got ageism, we've got technology, we've probably have some others. Well, I'm not seeing any thumbs down, so that's good. And let's see, I've already forgotten what that last question on the list was. Sarah, can you just read it to us?
I have it right here. What outreach should we consider?
Oh, yes. Yes, the question of, how do we spread the word, if you will? I mean, I just feel such a strong commitment among you all. But how do we start to broaden this conversation in the state of Maine? Certainly, hopefully, this report and other initiatives will help broaden the debate within the legislature. But other parties out there, thoughts for how we can grow the conversation, if you will.
I would love for us to get a charge to have some specific recommendations for future sort of consideration.
Yep.
And it seemed like today, like we listened a lot and reviewed a lot of information, but I love today where people were identifying some of those gaps. And it seems like if we could get in a room for a couple hours together, I think we could have some pretty amazing, some low-hanging fruit, some more stretch things that we might be able to do to really improve things, and then also help our legislature focus where they help support some energies to make a difference.
That's great. Thank you, Heidi. And if people have ideas for, if we were going more in the direction of recommendations, what would those be for you? We can start collecting those ideas now. There may be opportunities that arise during the session, but also next year is a new biennial process, and that tends to be when there are new initiatives launched, et cetera. So we'll be looking for ideas for sure.
Paul, who should we send those to?
If you can just send everything to Lauren, she's really our point on this. And we will send out a follow-up email after today's call, and we can make sure, you've got Lauren's email address, I know, but if you send them to any of us, we'll forward them to Lauren. So there's no wrong door here, but Lauren is going to ultimately be the one to synthesize and collect and help us think about these.
Thank you.
Anything else before we go? We've kept you a couple minutes over. Angie.
I think Angie's
I
hand.
wanted to mention that I saw a couple comments on PHI. We did this work on person-centered care for a few years, as everybody knows, through that Mayor Rothschild Foundation designation of excellence. I have been working with PHI, and I actually have written a whole proposal on person-centered care because I've done several CNA classes now. I've done a ton of them. And I see that people don't know how to make relationships. They don't understand really what person-centered care means. So PHI, I have put in a proposal to the Harold L. Fund for a significant amount of money to develop a program on person-centered care. And I am determined that I want to do this, but collectively with throughout the state, you know. I've talked to Brenda a little, Mary Lou knows a little about it, Ruta knows a little about it. So I'm waiting to hear back about that. So that's something that, you know, that could come forward to this committee to look at too. And it would be great if we could roll it out to all the nursing homes once we get it done. And it will have like a supervisors and a direct care aspect, both to it.
Great. Well, we'll look forward to learning more about that, Angie. Thank you.
Yeah, thank you.
Thank you all very much. This was very fruitful for us today, so I appreciate that. And I also appreciate all the contributions people. You're all very busy people throughout the year. We will collect your additional comments and people who were not here, and we'll finalize the report for this year and make sure that you have a copy as we release it. So thank you very much, and hope everybody enjoys a little time off over the holidays. Thanks, everybody.
Thank you all. Happy holidays.
Yeah, thank you so much, everybody.
Happy holiday, everybody.
Thank you.